Love this podcast? Support it and sponsor today. Simply head to ozcastnetwork.com for details.
Thank you for downloading and listening to This Pathological Life. If you're interested in continuing the story, we have a second series called This Medical Life. Please download it and subscribe now.
Dr. Travis Brown, why do we need a podcast called This Pathological Life?
Every disease has its own story to tell. So we're going to tell them.
Just before we get into this episode about prostate cancer, I have Dr. Troy Wallet, general practitioner, with me. Troy, if I were a patient coming to you with my tail between my legs, I feel like I need to have this digital examination on this pathway to understanding my risk of prostate cancer. What would your reaction be?
This is a very common presentation, and a lot of times men come in because either they're worried because their friends had prostate cancer, or they've been sent in by their loved ones or somebody that cares for them. And generally in these consults, it's really important to establish why they are there, what their concerns are, and then explain to them the risks and benefits of screening for these prostate tests, because obviously if they follow the path of getting tested, it can lead to negative outcomes, which will be explained more sort of through this podcast.
In this episode, we're looking at prostate cancer, Travis. And we have Dr. Bradley Webster joining us later to dive deep. But I've got a question without notice, if you don't mind. I've heard said that many men die with prostate cancer as opposed to dying of prostate cancer. Can I set that up as an opening saute for our conversation?
Certainly, and that is correct. It is interesting looking at prostate cancer to see that there are some forms of very aggressive. They tend to be in younger men, very aggressive, and these tend to be difficult and a challenge to manage. When you get a little bit into the older age brackets, so 70, 80, it tends to be quite what we call an indolent form of cancer. And so it's not aggressive. People will die of other causes from it. But it's always a bit of a challenge to work out. It almost behaves like a different disease in young people as to old people. I don't think we have a full grasp of why it behaves differently, but maybe Dr. Bradley Webster will be able to shed some light on that. But at the moment, I'm not aware of being able to differentiate. But it behaves very differently sometimes in younger patients as opposed to older patients.
That's got to be a challenge for GPs in their communication, because I'm a bloke and I just grasp onto that little insight and I think, well, there you go, I don't have to pay much attention to it. That's the dilemma. It is
a dilemma. It's hard, and this is where you can see the medical community and research and how our understanding grows with time, and it is trying to work out how something behaves, getting different indications, and this is why we did write the reports that we do, structured reports, and that hopefully gives us insight as to say, no, this one is aggressive or this one isn't, and we have staging and grading, and we try to put it into categories to know how it's going to behave.
And as a general pathologist, how does it intersect your world? There's
two areas. I will be involved in a lot of the chemistry area, so that's being overviewing the PSA testing, which is a chemistry testing, which we'll get into in a little bit. But occasionally I'll see some histology, but to be honest, I will generally defer that to the specialist histopathologist, because they report it every day. They know, deal with urologists at the time. So they will actually look at it down the microscope, put it into the category, write the reports. So
I am moving uncomfortably in my seat as we talk about this, but back in the history of time, the emergence of prostate cancer as a thing?
Well, actually, I might start with a question for you then, Steve. Okay.
This is not in my contract, by the way.
Let's look back 1927.
Okay.
So we've got a doctor, his name is Dr. Charles Huggins. So he is a young surgeon. He's actually appointed to the University of Chicago faculty as a urology surgeon, but he doesn't have any experience in urology.
Right.
So he crams for 4 to 6 weeks of the urology textbooks of the time and gets up to speed.
I'm worrying about where this is going.
Now, fortunately, he doesn't go to a busy clinic.
Okay.
So he decides he's going to set up shop and start to do metabolic examinations or metabolic tests. So I'm going to ask you, we've got the prostate. Now, you generally know, the interesting thing is about our textbooks of high school students is well above the physicians of, the 1800s. Right. So your knowledge is actually very good with regards to, physiology, anatomy. So you know where the prostate is.
Pretty close.
So Dr. Charles Huggins
Yes.
is saying, how do I get secretions from this organ and then test it to see how we go? How would you go about that?
Well, I imagine he's very hands-on as surgeons back in those days. How would I... Well, preferably you wouldn't want to prick anything down there because it's sensitive. So I don't... Look, Travis, this is very unfair.
It's a hard question, and this is what scientists have had to come up with all the time.
It's hard.
You have an organ that you're wanting to investigate more. How do you do that? What we know is where the prostate is located. So when we have things like sperm and semen going up, it comes from the testis. The problem is that then contaminates the secretions. So then you'll be measuring coming from the testis.
Yep.
The problem is it sits above the bladder, so it also drains urine going through it. So then how do you not get contamination from urine?
How did he solve this?
So he solved it by getting dogs involved, oddly enough.
Okay.
So you weren't going down that path?
No, I wasn't.
What we have is he's got a bladder that he's wanting to drain of urine.
Yep.
And then a prostate which he's wanting to get the secretions from.
Yep.
So what he's done is he does surgery on the dogs to put a catheter in the bladder and then stitches a drain into the prostate, and then he can get prostate secretions.
Okay.
So
This is back in 1927.
it is.
Right.
It is. So he then is able to start performing metabolic tests on the prostate to see what's going on and evaluate how that's going. So it's a bit of an interesting challenge, and particularly for a person who's...
I bet the dog would agree with that too.
But so what he ended up finding was when he got that, when he was able to get the secretions, he then found out that through desexing the dog, castration,
Yes.
when you took the testosterone away from the dog, the prostate shrunk. It involuted.
Oh.
So the hormone, testosterone, from the testis of the dog is involved in growth for the prostate. That in itself was very interesting, able to demonstrate that.
And a prostate enlarging is symptomatic of the issues, isn't it?
Yeah, yeah.
Okay.
So there is something that we call benign prostatic hyperplasia, so that's the prostate getting larger. Again, one of those ones where the applications are interesting. We then get to a point, though, and this is just through chance, that the dogs are one of the very rare animals that get prostate cancer.
That's where this quote would be appropriate, wouldn't it, Travis? This is from the good doctor. He said, "It was vexatious to encounter a dog with a prostatic tumour during a metabolic study."
So in his metabolic experiments, you started to find he was getting tumour cells in the secretions. Now, he wasn't sure how to deal with that. He initially thought, well, you have to take out the dog from the study because therefore it's a contaminant. But then what he realised is, well, what happens if we desects the dog, what happens to the tumour? The theory of the time is that cancer is unregulated proliferation of cells. Therefore, he shouldn't do anything. But he wasn't a cell biologist. And so he thought, if it shrinks the normal prostate, will it shrink the malignant tumour? And it did. It didn't just shrink it, it had a remarkable effect on the tumour cells within a few days. So then he realised that cancer cells still have some level of regulation within them from the testosterone hormone. What the metabolic experiments showed was that if you reintroduce testosterone, the prostate wouldn't shrink. So he realised that at that point in time, that the cancer cells still had a regulatory mechanism through hormones. And that changed for prostate and for breast cancer the understanding of malignancy and the pathways that it travelled down. He got the Nobel Prize for this in 1966 for physiology or medicine. It changed the way of our understanding of hormone regulation in cancer, particularly for prostate and breast.
I hope his dog got a reward for it as well.
He may have, you don't know.
You mentioned at the beginning we might be going down a rabbit hole with this discussion. I think we need to pause for a moment, readjust our sitting, and come back in just a moment to actually delve into this PSA testing, because I'm hoping what I can do these days is a lot more comfortable than what his dogs had to put up with. So, Dr. Troy, if I could just interrupt, I got the suspicious insight then that I might be able to leave your surgery without having to have this digital exam. Now, I'd like to know, first of all, have I grasped that correctly? And if I have, how do you know that we've all understood the decision I'm making to not have either the digital exam or the PSA test clearly?
But I often think about the psychology of people, or just the way that people work. And there's multiple layers here, because I can sit and tell them everything that I know, but people will still sit there and go, yes, and often jump at the chance of not getting the prostate test because they didn't want it in the first place. There's also this protection aspect, and I hate to think kind of legally, but you kind of have to do a little bit, because if in 3 months' time the person ends up getting cancer, when they think back to the consult, they will have a feeling rather than remember the words. And the feeling that they may get is that they were persuaded not to get the test. And I'm very aware of that. So one of the tricks that I do is that once I've had the discussion with them, I write out the pathology form that'll have PSA testing on the form, and I get them to cross it out. So then on my software, on my medical software, it'll say the test and it'll have PSA written there, and I'll document patient crossed it out. And often they'll cross it out in front of me. Sometimes they'll say, I'll go and have the test, I'll go and talk to my wife or my loved one and get it crossed out to them. But that way, if it ever comes back to me, I can say to them, well, I actually gave you the test and you made the decision and you crossed it out. So that's just a little tip that I have, understanding people and understanding that they don't remember the words, they remember the feeling.
All right, I'm not good at these sorts of topics because they're very close to home, Travis, but let's gear up for Act 2 as we go deeper into the realm of prostate cancer. So we've had those first discoveries. Where are we now historically? So
the prostate's been known about but probably ignored, mainly for thousands of years. We have Herophilus of Chalcedon and Galen of Pergamum who write about it.
Glands which poured a humour into the urinary passages of the male to excite the sexual act.
And so that's pretty much what it was thought about for thousands of years. We then get Andreas of Vesalius, who is quoted as rediscovering the prostate when he noted that it was a fleshy organ under the bladder. And this is where you get into, when you start getting into the urology surgery, you end up going down a rabbit hole, because there's things where we don't see it so much these days. It is, but what they talk about bladder stones and kidney stones. There's there's a procedure written about extensively in medical, well, let's say journals and textbooks about what they call perineal lithotomy. Now, your perineum is the bit between genitals and the anus.
Okay.
And so when we're talking about bladder stones, effectively we're saying surgeons of ancient times used to do what they would call cut for the stone. And so using a hook and a knife, they would then cut for the stone. And so this is, again, pre-anesthetic. Look, it's hard to read because effectively someone would be put in a position with two men holding legs, and then they would go through the perineum. They would have a knife and a hook, and about 50% of people died from the procedure, but those who didn't probably got rid of their bladder stones. I'm not sure if it was worth it, but these people were surgeons. Even Hippocrates, in his Hippocratic Oath, said he wouldn't cut for the stone. He would leave that to people trained in that field.
Right.
And then you've got some of the Roman surgeons saying it was not safe to do it in a pediatric population because the prostate, presumably because the prostate was too large to cut through and that would cause other problems. So, yes, it's an interesting reading exercise in that. We do have evidence. There's actually two of the oldest cases that we know. The one is an Egyptian mummy who's known as M1, which is 2,250 years old. He was a man 50 to 60 years old, but because now we have high-resolution CT and his mummy was intact, we know that there was actually small, dense, round objects throughout his pelvis, his lumbar spine, his arms and legs, and he would have died because of metastatic prostate cancer. There is an older case, which is 2,700 years ago, which is a Scythian king. This is from the Eurasian steppe. It found in a very ornate tomb, but the issue for him was effectively almost his entire skeleton was involved. So this was a man who would have been in a lot of pain. They couldn't find any normal bone on microscopy, so it almost looks like his entire skeleton was involved. So this is an ancient disease. There is theories out there, and there is some evidence that it's because humans started eating meat and the carcinogens in that started to affect prostate. And there is some studies that suggest people who are strict vegans have lower rates of prostate cancer in that. Again, it's
not quite as simple as that, though, is it?
No. And again, we don't have a magic bullet as to why it's caused, what's going on with it. But one of the things that we've mentioned is the grading. And we do have a grading scheme. It's from a Dr. Donaldson Gleason, who did a grading scheme in 1966. He was asked by a urology department, because there were so many different grading schemes, no consistency, he came up with the grading score that we use to this day. There's been a few modifications, but effectively what it was is he did a map of all the different kinds of glands that you could find that were abnormal and malignant, and then he put them into grades, and effectively it was sort of grades 1 to 5, 1 looking like normal tissue all the way through to 5, which is pretty much sheets of cells. And then from there, we were able to work out, this behaves badly and this behaves better. And then from there, that takes us to the PSA testing.
Yes, which I was hoping is going to be my easy way without the doctor needing to be all that invasive for my checkup.
PSA is actually a controversial all the way through. Like even at its beginning, like it was identified in between 20 years, in 1960 to 1980. There's about 8 different scientists who claim that they've discovered it. Some people attributing something with, yes, this author helped her. So it's mired in controversy. But we do have PSA. So it's a blood test that we take, sometimes referred to as a tumor marker, but it's a protein. Secretions from the prostate, seminal vesicles, have PSA in it. So what PSA is it dissolves seminal coagulum. So it's important for fertility and sperm motility. It's in the most concentration in semen, but a small amount of it goes into blood. It's about a 1/1,000,000th concentration goes into the blood. And we can test that. The problem with PSA is that most of the conditions that increase PSA's value in the serum don't have anything to do with malignancy.
Meaning false positives?
So, well, it's not false positives because it's elevated in the normal condition, meaning that if you're testing for cancer, let's say 4 men have an elevated PSA, 3 will not be related with cancer. So there'll be other conditions that raise it, meaning that at a population level, that's a really bad screening test because a lot of people will be getting positive tests that don't have cancer.
And yet here I am feeling guilty because I have been putting my GP under pressure to just do the PSA test. That's all I want. And he pushes back. I mean, quite literally. Yeah. But I just... So that itself is a communication challenge because we just get the wrong end of the stick.
The challenge with PSA is for people who have prostate cancer and then have the prostate removed, it's actually a really good test because you should have all your normal prostate tissue as well as the cancerous tissue removed. Mm-hmm. Now, as we know, if you take the prostate all out, then there should be no PSA because there's no tissue able to make it. Okay. The interesting thing about that is if the glands or some of the malignant cells have moved, they will still be producing PSA as their normal function, but it's malignant cells. So that is when, if you detect PSA in someone who's had their prostate out, then that's an abnormal result. So in someone, as a screening population test, not a good test in that area. For someone who's had their prostate out, that shouldn't have any prostatic tissue left at all. It's a very good monitor to see if anything's producing PSA.
Would you be offended if I got a second opinion from Dr. Bradley Webster?
Absolutely not.
Because he's just about to join us to continue this discussion about prostate cancer.
The weird thing was, 3 months after the appendix operation, still in a lot of pain. So they sent me for a prostate exam. Hey! Have you had that one, my friend? Yep, you just gave it a thumbs up, so I'm assuming that's a yes and how it happened. The thing is, not enough men in Australia are having their prostate checked. And it's because men are scared. Men are generally scared that it's going to be the most painful thing in the world. But I'm here to tell you right now, from experience, as a community health announcement, it will only hurt if your prostate's inflamed. And if your prostate's inflamed, it's a good thing you're seeing a doctor anyway, so it's just as well you're there. If your prostate's healthy, in all honesty, feels kind of nice.
As mentioned earlier, we are being joined now by Dr. Bradley Webster, although you have said I can say Brad.
That's right.
All right, Brad, welcome. Brad is a histopathologist in ClinPath, specialising in uropathology and lymphoid pathology.
That's correct, you got it right.
I did. I was trying to hemolymphoid pathology, to be correct. All right, so let's continue our discussion of prostate cancer now.
Brad, can you give us a bit of background as to how common prostate cancer is?
That sounds like an easy question, but there are actually two parts to the answer there. So prostate cancer is the most common male non-skin cancer. So obviously there are skin cancers like basal cell carcinoma and squamous cell carcinoma, which are much more common than all the other cancers. But in terms of non-skin cancers, prostate cancer is the most common in men. Your lifetime risk as a male of getting prostate cancer is about 10%. But they've done studies on older deceased gentlemen, so we're talking autopsy studies here, where they've looked at the entire prostate, and what they've found is about 40 to 50% of them have tiny foci of prostate cancer. It follows then that a significant proportion of men will have cancer and never know it, and they'll die with the cancer rather than from the cancer. And I think that is the essence of I guess the difficulties that we have to deal with when we're treating or trying to diagnose prostate cancer.
Well, Steve actually started with the question, so how most people die with prostate cancer than from prostate cancer, and I agreed, but clearly those statistics are...
Yeah, it's quite surprising, I think. Often we'll get specimens for bladder cancer in males that will have the bladder and the prostate comes out with it. And we know that it's being taken out for bladder cancer, but often we'll see small incidental tumours in the prostate. And again, often they're low grade, so they're tumours that would never have or in all likelihood would never have given the patient any problems.
How does it present then? How will prostate cancer that's significant present?
The presentation of prostate cancer these days, now that we have PSA screening, is usually it's by doing the PSA test and then by the core biopsies that you'll go on to get if you have a raised PSA.
Brad, if I can just interrupt, PSA, Travis and I were talking about it earlier and talking about some grey areas. What's your perspective on the usefulness of this as a test?
Yeah, you're right. It is a very grey area. And it is controversial. And I think that as more data comes out, the recommendations do change. It's very useful once a patient's had therapy, once we know they have prostate cancer and we can follow them. So once they've had a prostatectomy, in theory, there shouldn't be any PSA detectable. So if there is a rise in PSA, then that means, okay, maybe there's some prostate cancer remaining. In terms of population screening, the idea behind, I think, population screening is we want to detect tumours at an earlier time point before they can go on to cause morbidity and mortality. And the issue with PSA is that although it can be increased by the presence of a tumour, it can also be increased by benign things. So BPH, which is benign prostatic hyperplasia or hypertrophy, that's quite common in older men, and that can also increase the PSA. Inflammation of the prostate, trauma. So if you're an avid bike rider, sitting on a seat all day, putting in hours, that can also increase your PSA.
Good, I'm safe on that one.
We have age-defined ranges for PSA, and if you do have a PSA test and you're above that range, then you should go on to have a biopsy, unless there are obvious reasons why the PSA should be elevated. But because it's a low specificity test, then a lot of men will have a biopsy to show that they have a normal prostate. But at the same time, we will pick up a lot of tumours which otherwise would have gone unnoticed. And the question is that a lot of these tumours are also going to be these low-grade tumours we talked about. And then I think that's where the argument about population-level screening using PSA pops up, is that we know that a lot of these low-grade tumours would never have caused the patient problems. So there is a potential for over-treatment. And that, I think, is the dilemma in prostate cancer. We want to detect prostate cancers, and we want to treat the ones that are going to cause harm to the patient, and at the same time not over-treat the tumours that would never have done any harm. The patient, could have lived a full life and not have even known that they were there. Before PSA screening, prostate cancer presented at a more advanced stage. So most men who have ever gone to the doctors to have their prostate checked up would know that a digital rectal exam is one of the simplest tests. So that's basically finger up the backside and seeing if you can feel a hard or irregular prostate. So in order for a tumour to be palpable, it often has to be quite large or quite advanced. By the time you can feel it, it's bigger than what it might be if you detected it by PSA screening. In the past, prostate cancer might be, the first presentation might be with quite advanced disease, so with metastasis, so it might be with bone pain, or it might be the tumours invading into adjacent organs. It might be picked up by incidental imaging, so a CT scan might find evidence of metastases. What's interesting is that the prostate surrounds the urethra, and we know that older men can have difficulties with the waterworks, and that's because the prostate becomes quite nodular and can impede the flow of urine through the urethra. But most prostate cancer actually arises at the periphery of the gland, so it's quite unusual for prostate cancer to present with urinary difficulties, although it can happen.
How does it behave biologically then?
Yeah, so it's this bit of a disconnect there between 10%, there's a lifetime risk of 10% of clinically detectable prostate cancer, but we know that about 40 to 50% of men over the age of 50 in autopsy studies will have prostate cancer. So there's this spectrum of biological behavior in prostate cancer. So these low-grade tumours have quite an indolent behavior, and then that spectrum goes all the way through to highly aggressive tumours, which which will kill the patient. So the fact that we have these low-grade tumours, we don't want to necessarily overtreat the patient, because we know that these patients will live with the cancer and die with it, but not from it. So there's a strategy that urologists use called active surveillance or watchful waiting. So that's basically they'll follow the patient, they might look at the PSA levels, they might do biopsies, and they'll just follow that patient, this over years, and to see at what point whether they need to take on more aggressive course of action.
Does that include having biopsies and getting graded, staged?
It's probably a good time to talk about grades now that we're talking about the spectrum of biological behaviour. When we talk about tumour grade, we're basically talking about what's the sort of intrinsic aggressiveness or intrinsic biological behaviour of that tumour. So we know prostate cancers, it's not one homogeneous group, but it has a wide range of behaviour. So we apply a grading system, which we've probably already talked about, which is the Gleason grading system. Basically, in the 60s, this guy called Gleason, he was given the task of trying to come up with a way of predicting the behaviour of prostate cancer by looking at it under the microscope. And he found that there were about 5 different patterns under the microscope, which funnily enough were numbered 1 through to 5. So 1 looked very much like normal prostate tissue, and 5 was clearly malignant, so it had lost any architectural features of the normal prostate. And what he found is that if you added the most common pattern to the second most common pattern, that would give you the best indicator of how that tumour might act. Because there are scores from 1 to 5, we add them together. So in theory, you could have a tumour, the lowest grade would be 1 + 1 = 2, and the highest grade would be 5 + 5 = 10. In practice, though, grades 1 and 2 we don't use. So really it's scores of 3, 4, and 5. So the lowest grade tumour you can have is a 3 + 3 = 6, and the highest grade tumour, it would be a 5 + 5 = 10. That can become confusing for a patient, because the urologist might say, well, if you're going to have a prostate cancer, the best one to have is this that you've got, 3 + 3 = 6. And the patient thinks, well, why don't I have 1? Surely 1 is better than 6.
Yeah.
So to overcome this confusion, they now have what's called a grade group. So the lowest grade tumours, which would be a 3 + 3 = 6, is now called grade group 1. And there are 5 main grade groups, 1 through to 5.
Is that now the terminology that is preferred by doctors or urologists, or?
We use both because the pathologist still works in terms of the Gleason grading system. So we'll come up with the Gleason grade first, and then we'll convert that into the grade group.
Is that the best measure we have for prognosis as to this is how it's going to behave?
There's been so much work for all tumour types on genetics and the molecular features of tumours, but in terms of routine clinical practice, the Gleason grading is the most powerful prognostic indicator that we use. We also use stage, which is a measure of how far along the tumour is in its natural history. So is it confined to the prostate, or is it spreading out of the prostate and invading adjacent organs? But the Gleason grade gives us the best idea of how this tumour is going to act. So just going back, if we know that there's a range of behaviour of prostate tumours, and we have this grading system that works quite well, and it's quite amazing that it has been tweaked a little bit since the 60s, but it's essentially the same thing. So if we know how aggressive a tumour is going to be, then we know how hard we need to go at it. We know whether do we need to go straight to surgery. Will it fit into the watchful waiting criteria? Mm-hmm. But obviously, you can't necessarily answer those questions without knowing the patient. It's not a black and white, hard and fast rule. So there's a conversation between oncologists or urologists and the patient, and that's dependent upon patient age or their comorbidities. So essentially, their life expectancy. So if an 85-year-old with poor health has a diagnosis of a low grade, maybe not 3 + 3, but maybe 3 + 4 = 7 prostate cancer, their life expectancy may be shorter than what the tumour, in the time it'll take for the tumours to get them. So they might, a surgical intervention may not be the best choice for them.
I was going to ask the role of imaging then with regards to the MRI or other imaging. What role do they play in all of this now?
Yeah, so MRIs, they're relatively recent in terms of their use in prostate cancer. So 10 years ago when I was training, they weren't all that common, but now a lot more patients are getting them. When the urologist does the core biopsies of the prostate, we're sampling a very small proportion of the prostate. So it might be 1,000th or 1/10,000th of the actual prostate volume. So before we had the MRIs, the question is how do you go about sampling it? So you have to be systematic and you sample all the different areas and hope that you hit the tumour. So if you do hit the tumour and you have a low-grade tumour, is that necessarily completely representative of the tumour? Have we just sampled a low-grade area of a tumour and there might be a high-grade area elsewhere? And I think that's where imaging helps. So with the MRI, we can see, okay, where exactly is this nodule, which might be suspicious for a cancer? Where is that in the prostate? And can we target it with more biopsies in that area? So that helps in terms of knowing whether you've actually sampled the tumour. There are other imaging techniques that we've got now. So there's a PSMA PET scan. So PSMA is a protein produced by prostate cells. What we have is a molecule which can specifically bind to PSMA, and it's attached to a radioactive tracer. And then that's injected into the patient, and that will go and seek out and attach to the tumour. And then the patient's put into a PET scanner. And the idea behind that is we want to be able to pick up a metastatic disease. So if the patient has metastases, it's a surgical intervention. So taking out the prostate is a futile exercise, essentially. So this PSMA scan is a very specific way of detecting small deposits of tumour that have got outside the prostate.
Is there any role at the moment, because molecular pathology is for tumour marking and identifying is coming along in leaps and bounds, but is there any role for that at the moment for prostate cancer? So
at the moment in our day-to-day practice, there's no role for molecular in terms of diagnosis or prognosis, but I think that's what we're working towards. I suspect in our lifetime we'll come up with a way in order to predict which of these tumours are the ones that need to be aggressively treated and which ones can be left alone and followed.
Thank you very much, Brad. Appreciate that. So me as an Aussie male now will take more notice of my own maintenance, let my GP do what the GP needs to do, and I'll give up digital self-examination for the time being. But thanks again for joining us.
Thank you.
Okay. Thank you.
This Pathological Life is produced by ClinPath Pathology in South Australia. Episode notes, references and learning objectives, when applicable, can be found at thispathological.life.com.au. And you can contact the hosts on Twitter via @Dr. Travis Brown or @Steve Davis. Thanks again for listening, and just a reminder, if you haven't done it yet, have a quick search in your podcast app for our second series, This Medical Life. Dr. Travis Brown has rolled up some extra guests, some extra topics, and we continue the story there, and we'd love to have you along.
Love this podcast? Support it and sponsor today. Simply head to AuscastNetwork.com for details.